Okay, so hello and welcome to this free session. Please mute your mics, otherwise I can't continue. Okay, so welcome to this session on Introduction to the Mrcog Part 3 exam. The session is all about understanding the Part 3. So Mrcog exam as a whole, I think it's more about understanding what the exam is about and how to approach preparation for the exam and then perform in the exam. So it's about understanding. If you understand the exam well, it's easy to pass, and that includes all the parts. Part 1 is a simpler part of the exam is what I feel. It is difficult in the sense that you had to study all the basic sciences which you had studied long back. But actually part 2 and part 3 are the tough parts of the exam. And in my opinion, part 2 is the toughest part of the exam. And all of you who are here today have already cleared part 2. So the hard part is already over. Part 3 is more about strategy and preparation. So we're going to touch on these aspects of preparation. So how to approach it and how can we clear it, in your first attempt or the next attempt which you are giving. Some of you may have appeared in the exam and unfortunately not able to clear. Nothing to lose heart. It's the nature of the exam that even if you know a lot, sometimes the exam day, how your mind is working, if you're not relaxed, you're very tense, sometimes you're not able to perform up to the mark, although your clinical knowledge may be excellent. So staying calm and composed during the exam is very important. So it's a long journey. I know the Mrcog is a long journey, going through part 1, 2, and 3. And nowadays we see that many people are not able to secure a place in the exam. So it needs continuation of preparation so that whenever you get a place in the exam, you are able to attempt it with your maximum preparation. So the journey, I always put a lot of quotes in my lectures and presentations. And one very famous quote by a Chinese philosopher says that the journey of 1,000 miles begins with one step. So the journey may be long and it may take a long time, but it starts with the first step. So now we try to take that first step in understanding what we are supposed to do. We here at Exam Expert have been running Mrcog preparation courses for some time now for part 1, 2, and 3. Part 3 courses started last August, and we have done many batches now, and we have received a lot of good feedback, some feedback for improvement, and we try to keep improving with all the feedback. But generally the feedback has been very good and good results, and we are happy. Just one batch of students has appeared for the November exam, and we wish all of them the very best, and we hope to have good results for that. So as I said that this is the first, you have to take the first step and try to understand the exam, and slowly and steadily and not losing patience. You have to keep going on and on. And this is very important for us to have a lot of patience, because it's not a 1 or 2 days process. It's a process of many months. And at some point of time in between, you feel that you don't have time, or you could not study 1 day or 2 days or maybe few days, because I know all of us give the exam while we are working, and we have to balance family life and professional life and then also study for the exam. So there will be few days that you become very frustrated that I don't have time, I was not able to study, or you feel that I'm not performing well when you practice. But that's all normal, natural, that happens with everyone. You just have to keep going and then you will reach your destination. Let's move forward. So patience, persistence, and perspiration make an unbeatable combination for success. So you need all these. You may be thinking that I'm just throwing literature at you when we have to, you know, understand about a medical exam, but I will vouch for the fact that these things are as important as studying the guidelines for this part of the exam. So you need to have patience, you should be persistent in your preparation, and you should be ready for hard work. All of these things are very important. So the communication skills we are looking at, now you all know that this is an exam about communication. So communication means listening. And this communication skills, I mean, is when you prepare. So I'm talking about preparation. So listening. So you have to listen to the role player. So when you're practicing, you have to listen to your role player or friend you're talking with. Writing. You would have, during the course of preparation, you need to write. And what I mean by writing is that you have to make your own notes for preparation, make your own templates for different kind of stations. People want to get all ready-made templates, and you have a lot of ready-made templates on the internet, on the various Telegram and WhatsApp groups. But mind you, it's a good idea to have a ready-made template, but you should read it, and I will suggest write it in your own words, in your own handwriting, so that once you're in the exam, you are not, presenting something from your rote memory that you have just memorized it and speaking. If you speak your own words, it is more effective communication. Reading, need to read a lot of information, books, guidelines, various other sources like strategy. And last but not the least is speaking. So if a combined effect of listening, writing, and reading will actually lead to speaking, which is actually the exam. So you speak in the exam, and whatever you speak is going to fetch you marks. Okay, so let's move on. Just a short thing about rules and regulation. I always speak these things because sometimes people are confused. So everything is given on the RCOG website. For any procedural or technical details about the exam, you should always refer to the RCOG website. They keep updating, and sometimes there may be new information coming up, which the only source is the RCOG website. You trust that source, so maybe you can log into the RCOG website and keep checking it. So it's a standalone exam, as you know now, and within 7 years of the Part 2 exam, it has to be attempted. Each candidate is allowed 4 attempts after Part 2. If one is not able to clear the exam even after 4 attempts, will have to repeat Part 2 exam. Now the venues this time were London, Singapore, Hong Kong, Delhi, and even Chennai in India. So India had 2 centers. The next exam is in May 2020, 11th to 14th of May. The venues have not been announced yet on the website. I saw the website today. The venues we don't know, but mostly all the 4 centers we expect, but 100% can't say. Only once the RCOG announces on its website, it becomes clear which venues will be there. After May, the exam will be in November 2020, which is 2nd to 5th November. So I'm sure those who are listening today may be targeting either of the 2 exams. After this slide, I'm going to only talk about the May exam and how we approach it. So what happens in the exam, you all know, it's a circuit exam with 14 stations. Each station has 12 minutes, and 2 minutes out of which is the reading time when you read the question, read the scenario given to you, and after that the bell rings. So the first bell is starting of that 2 minutes. The next bell is the completion of the 2 minutes and the starting of the actual station, in which you go inside the cubicle and face the station. And after that, 10 minutes, the bell rings and you are on the next station. So it goes on and on. So it's total 168 minutes exam. You have two kind of stations, the role player stations or the simulated patient task, in which there is an actor who is playing the role of a patient, and then and the actor has a script, and then you have to talk to the role player as if you will talk to a patient, and then discuss the history, the problem the patient has, and explain the management. One of them will be a teaching station, in which the role player is actually posing as a junior colleague, and then you are going to teach some aspect of medicine, maybe some procedure or some, something like a CTG. That will be the teaching station. The other type of station are structured discussion with the examiner. This is a kind of a viva in which you are explaining the management to the consultant or your senior colleague. The difference between the two stations is very evident. The role player stations, which is a patient, so it will be in layman terms, in layman language is how you talk. Contrasting to this, structured discussion is with a medical person who's a senior, who's a consultant, so it will be all scientific terms. Just to mention is that many of the courses, they have increased the number of structured discussions in the exam, and though it is not on the website yet, but there have been news or rumors saying that the number of structured discussions may increase in the future, so we keep a lookout for that. After that, there is a concept of the lay examiner also, which you should understand. 4 of the stations in the exam will also have a lay examiner. This is in role player station. A lay examiner is also a trained examiner, but comes from the lay public, not a medical person, who again tests you for various domains like communication skills, or patient safety, or information gathering. So in those stations where the lay examiner is sitting, are your high yield or your most important stations. So what do you expect is that you have various cubicles. So you have 14 cubicles. The candidate instructions are pasted outside. So the 2 minutes you get, you have to read those candidate instructions. On the same day of the exam, same stations come. So sometimes the exam is on 2 days, sometimes on 4 days. Like this time, the exam in few centers was for 2 days. In London, it was for 4 days. So each day, generally, the stations are different. But same day, morning and evening sessions, the stations are the same. Those stations, as I told you just now, with 3 people inside, the role player, the clinical, as well as the lay examiner, will definitely carry the highest marks, because both the clinical examiner and the lay examiner are going to mark you on the same station. And you rotate the circuit without any break. So you have to target those 168 minutes, which decide your result. So the modules, all of us know that. Just to reiterate: teaching, core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, postpartum problems, gynecological problems, subfertility, sexual reproductive health, early pregnancy care, gynecological oncology, and urogynecological and urogynecology. Why I want to put this slide, this already all of you know, is that you have to spend equal time on each of the stations, each of the modules. This is because you will get 1 station from each module in the exam. Generally, that's how it goes. So some of the modules you will find that they are smaller. So the amount you have to read is small. The stations which come are limited. So spending lesser time on those modules will yield more benefits. Like for example, if you take the subfertility module, to some extent, it is a limited module. So it's a fixed number of things you need to study, and fixed, generally, we know what kind of stations might be coming from subfertility. So if you spend that much time, your yield of knowing the type of station and doing different kind of stations is more. Similarly, for something like urogynecology. So if I see urogynecology as the number of the type of stations, I think are stress incontinence, urge incontinence, fixed incontinence, false prolapse, interpretation of a urodynamic graph, and the tapes for incontinence, surgeries for urogynecology, bladder pain syndrome. So after that, no more. So what I mean to say is there's a limited number of stations. So if you prepare all of them, one of them will come in the exam. If I compare it to something, an obstetric module, something like maternal medicine, which contains all the kinds of medical problems that may affect pregnancy and their management. So the amount of time you have to spend to do all those things in maternal medicine is too much, and you will never be able to actually complete all the possible medical conditions in pregnancy. So that way, you need to decide and strategize how much time you are going to spend on each module. So in the bigger modules, you may need to spend more time, but it should not be so much that you neglect the smaller modules, which are going to again yield a station as well. So divide your time wisely. Now let us now go on to the marking scheme. So this is something anybody who starts preparing for part 3 gets stuck here. Domains. So because the marking will be on domains. So each question, if you get in the exam, the question will say that you will be assessed on the domains, and the domains will be given to you, which domains you will be assessed. Generally, each station, 3 to 4 domains may be tested. The domains are information gathering, communication with patient and relatives, communication with the colleagues, applied clinical knowledge, and patient safety. Each domain, the candidate is marked as pass, which is 2, borderline, which is 1, and fail, which is a 0. So 2, 1, or 2. And later on, all the scores from all the domains of all the stations are actually added to calculate your result. So there will be a normal cutoff for the exam. Generally, it is 62, 63, 64%. If you reach the cutoff, cross it, then you pass. If anyone who is not able to reach that cutoff, unfortunately, will not be able to clear the exam. Also to remember, individually in each domain, one doesn't need to pass. One just has to have a total reaching the cutoff. But definitely everyone has to perform well in each domain to have an overall good score. Let me move back to the domains, and let us discuss what these domains are. First, let me talk about information gathering. So maybe I'll ask someone, anybody wants to volunteer and tell me about information gathering? Just 1 minute. Anybody? Because I want it to be an interactive session rather than, me speaking continuously. Anyone wants to talk for 1 minute about information gathering? See, I don't have much time, so I can't keep waiting. Any volunteer, or I move forward?
Hello, Dr.
Hello, madam.
Pooja.
Good evening. Hello, madam.
Hello.
Good evening.
One person who's speaking?
Yeah, I'm Krish here.
Hi, Krish. Welcome to
hello, doctor.
session.
Thank you. Doctor, actually, information gathering means about the presenting compliance, the history of the presenting compliance, then about everything about the details about the current compliance and what is her presentation, and then what is her concerns, all that we'll have to address. And then we have to ask a detailed history about her past obstetric organic history according to the case, and a medical history, a family history, social history, and any relevant history relating to her habits that comes under social history. And then we have to ask about her blood group and any restrictions for blood transfusion like that. And then we have to ask about then we have to summarize a bit of all this, and then we have to examine her, asking her permission to, I mean, in the presence of a chaperone, and do the relevant examination, the general and the systemic examination, and the obstetric or the gynec examination, or any other system if it is involved, and then do the necessary investigations. That's what is my understanding of information gathering.
Okay, so well said. So it's
Thank you.
quite a self-explanatory kind of a domain. Now, information gathering is the history taking, examination, investigation, whether they are given to you in the question or they are given to you once you ask for it. And then using that information, so using that information which is relevant to the question is also important. So irrelevant information is of no use, but using the information, so whether you are tested on whether you are able to extract the relevant and appropriate information. Okay, so the relevant and appropriate information so that you are able to reach the diagnosis and then thereby explain the management of the patient is actually information gathering. So what do we require for information gathering is one needs to have an organized template in mind. So there is a basic template for history taking, but again, from module to module, from station to station, there may be some differences. So you should have that template in mind and you should be organized about it. When you are disorganized, the problem in the exam is that you only have 10 minutes. So if you are still sitting in your outpatient department and you're talking to patient, you have much more time. You can speak, think and speak. But in the exam scenario, when you have only 10 minutes to ask the history, assess it, and explain the management plan, you don't have more than 3 to 4 minutes or maximum 5 minutes for information gathering. So you should have an organized template in your mind in any station you present, because unless you have that, the history goes all haphazard and takes more time, and then sometimes you miss important points. So having the organized template is important for both the reasons. Any examination you are suggesting to the patient, you need to justify it, why you are doing the examination. And investigations also as well. If you are offering some investigation to the patient, you need to justify why you are doing it in that particular case. And the ability to interpret all to reach a diagnosis and then explain management. Checking understanding of the patient also is part of information gathering. Knowing what her chief concerns are is also part of information gathering, because many of the questions will have, to address her concerns. Now, you can only address her concern if you know what her concern is. So, like I say, case of a patient comes to you with premature ovarian insufficiency, her chief concern may be fertility and not that she has gone into menopause. So, you have to understand and then counsel her accordingly. Information gathering involves a combination of both open and closed questions. So that we keep discussing as we keep doing stations. We'll discuss how you need to gather information. Also, in case of sensitive questions, you need to have, your communication skills have to be very good for information gathering. So information gathering also involves communication skills when you're asking sensitive questions. Okay, next is communication with patients and relatives. So anyone who can just enumerate the points you need to be aware of when you're communicating with patients or relatives. Anyone? Again, only 30-40 seconds. Communication with patients. What do you know about this domain? Quickly. Okay,
Hello,
Divya?
hello. Uh,
Yeah,
uh,
hi. Divya Lakshmi?
yes, ma'am, yes, ma'am.
Yeah, please go on. What are the important points you should consider, or what comes to your mind when I say the domain communication with patient and relative?
About communication with the patient relatives, first will be the proper introduction and developing a rapport,
Okay,
confirming the identity of the patient, age and name of the patient, then asking about her complaints or the concerns, then addressing her concerns properly, giving proper like uh, how to say um, maintaining the confidentiality um, um, and um, so uh,
okay, it's fine. Okay,
uh,
no problem. Fine.
then
So, okay, communication with patient is, yeah, communication with patient means, okay, introduction, introducing yourself, asking the patient introduction. Signposting is one of the important points of communication. What do you mean by signposting is when there is a sensitive thing, or
okay,
like you are asking about sensitive questions. If you want to ask sensitive question, you have to signpost. Suppose you want to ask about addictions, you want to ask about, if you think there is something hidden, there is a domestic abuse, you have to signpost. You say that I'm sorry that I am going to ask you a sensitive question. Okay. So this you have to signpost. The other kind of signposting is when you talk about, when you have to break bad news. Patient has cancer, fetal anomaly, or entire and feels that, say that I'm sorry, I don't have any good news for you. So that is signposting. So signposting is an important part of communication with patient. The other thing is empathy. So you have to have empathy with the patient, because patient has come to you because patient has a problem, has a medical issue. So you have to empathize. So that empathy should come forward in your all your mannerism, in your tone, or the way you talk to the patient. Then honesty. Honesty means, suppose there's a problem which has happened, there's a negligence which has happened, there's a complication which has happened, and it is due to some shortcoming on the part of the doctor or this thing. You have to be honest about it. You have duty of candor. You have to explain to the patient what has happened. Okay. Avoiding medical jargon. Avoiding medical jargon is another point. When you are talking to a simulated uh, patient or a role player, you have to use patient layman language or patient friendly language. So you should avoid scientific terms. This is very important. Okay. Using aids to explain. Maybe you draw diagrams which you are used to, which helps the patient to understand better. Okay. So like then other small things, like if it's an early pregnancy, patient has come for a early pregnancy antenatal care visit. To ask if this was a planned pregnancy, she says yes. You say congratulations. But you should remember, it should not be a station of miscarriage or a molar pregnancy, and then you're saying congratulations. So you have to change your attitude, the way you are talking based on station. Okay. Sensitive questions, you have to be very careful. As I said again, signposts, ask them sensitively. Because it's like, say, domestic violence or sexual abuse or female genital mutilation, you have to be sensitive while asking this question. Otherwise, the role players are instructed not to answer. They will not bring out the history. So, if you see some station as domestic abuse, and from the station is very evident to you that it is domestic abuse, but unless the role player actually agrees that yes, she has been subjected to the domestic abuse, your station is not complete. So you have to be very sensitive. So not only what you are saying, but how you are saying it is important. So that involves how you are behaving, your body language, your attitude. Are you listening very well? And again, communication of patient doesn't mean the speaking part. As I said, listening. You have to listen to the patient. You have to listen to the role player. So that shows again your empathy, that you are communicating well. Secondly, it gives you hints. So as far as the exam is concerned, listening to the role player becomes very important. As I said, they have been given a script. They are following a script. They are actors. So if they have a script, and if there are some points in the script which is not evident on the question outside, the only way you can get to it is by listening to the role player, allowing the role player to speak and give you hints. So you would listen to the patient, and then address the concern. Okay. Then if the patient gives a positive reply to any of your history, just don't go, because you have a template in your mind, just go 1, 2, 3, 4. You have to respond to that, because sometimes the candidates they say, do you smoke? And the patient says yes. So they go to the next question, do you drink alcohol? But why did you ask the question about smoking if you're not going to respond to that? So the patient says yes, I'm smoking. So then you have to respond to that answer. So you say that, have you ever thought about quitting? If yes, then I can, through your GP, I can coordinate and refer you to the NHS Stop Smoking Services, and then they would help you to deal with this and help you to quit smoking in a better manner. Something like that. So you have to respond to what the answer came to you. So if you ask a question and the answer says yes, you have to respond to it. Okay. And so listening and speaking both are important. So this is the main points on communication with patient and relatives. Communication with colleagues. Now 15 seconds to answer. What do you understand? Communication with colleagues. What is there in this domain? Quickly. There are many people here. I think Anuradha, you wrote something on the chat. So what do you understand by communication with colleagues? So what do you understand in this domain?
So communication with the colleagues is like two parts, like mainly in the teaching session when you are talking to a junior. So it applies like introduction, how you convey the teaching part, whether how you are going to check his understanding and then take a feedback. The other part is like when you are communicating with the emergencies, other case scenarios in labor room or in gynecology ward. So it mainly uses SR2, where it is like situation, background, then assessment and the recommendations. So basically these two types of communications what I have seen in the exams.
Okay, good, correct. So one type of communication. So in the simulated patient task, there will be two kind of stations, which involve two kind of things, as she said, two kind of assessment of communication with colleagues. One is when you are teaching a junior colleague. So that is a direct communication with the colleague. So how are you dealing, or how are you treating your junior colleague? Are you able to understand what they are trying to learn? Are you able to impart learning, taking feedback, and without being, what do you say? Without being patronizing about it. So you should be able to be nice to the junior colleague and able to teach and take feedback, and also being able to uncover hidden agendas like bullying in a teaching station. So that is one thing we should remember. The other thing which Anuradha said was correct. It's communicating with colleagues in other scenarios like emergencies. Postpartum hemorrhage, you call for help, so you call various colleagues. So you have a midwife, a midwife supervisor, you have your senior, you have a hematologist, you have a laboratory person, you have a porter. So that is all communication with colleagues. The third thing, communication with colleagues, is when you liaise with different specialties. In a case like a urogynecologist, in case of urogynecology, stress incontinence, you have a multidisciplinary team. So the MDT also is communication with colleagues. In a case of cancer, you have a multidisciplinary team with the oncologist, with the cancer specialist nurse, with the people at the community level which are handling the patient, and the gynecologist. So all this is also communicating with colleagues. And the very important thing, the structured discussions. The other type of stations are the structured discussion, which definitely the domain which will be tested will be communication with colleagues. because here you are now communicating with a senior colleague, which is a consultant, so that those stations will definitely test the domain of communicating with colleagues. Here you have to communicate with a senior colleague, so you have to be very organized in what you're speaking. That is why it's called as a structured discussion. So you have a structure in your mind when you're telling the answer. You are using scientific terms, and you are able to delineate and outlay your management plan. So that is communication with colleagues. Okay. So many of the candidates, many of our students have a lot of difficulty in handling the structured discussion stations, because though they are straightforward in a way that, they directly, if you know the guideline well, you have the clinical knowledge about it. But sometimes to structure the answers in a proper format, when you don't know in a particular question till what level you should go, and you don't know what the other questions are going to follow. So you have to be very structured in your thoughts and in what you speak. That is why they're known as structured discussion. So the structured discussion station definitely will have this domain of communication with colleagues. Keeping that in mind, that many of us find a lot of difficulty in doing the structured discussion station. In our course, in addition to the normal stations which are going on, or each module, there will be structured discussions. We keep a separate session on structured discussion, which around 5 stations will be only structured discussion, to give you more practice and to understand how to attempt these stations. Okay. Next domain is applied clinical knowledge. So this is quite self-explanatory, and this is something which you understand very well. The applied clinical knowledge, because applied clinical knowledge means whatever knowledge you have gained from the various sources. So you have guidelines, you have strategy, you have talk articles, and all other sources of information is applied clinical knowledge. So the applied clinical knowledge is that you know what is there in the text, and then you apply that knowledge to actually make a plan for the patient. So applied clinical knowledge will be used in making a diagnosis. Applied clinical knowledge is also involved in actually asking the relevant questions. So actually all the domains are slightly interlinked. So you make a plan of management for the patient based on the applied clinical knowledge, and before that you even ask questions relevant to the particular situation. That's also applied clinical knowledge. And then you have to explain that management plan. So if you have gynae cases in which you decide the gynae management and the obstetrics. In the obstetrics, the plan may be for antenatal care, intrapartum, postpartum care, which you may need to describe. Then you should know that, in some cases, high-risk pregnancies, the patient is under consultant-led care. Then something like a gynae case with like heavy menstrual bleeding, you should know that there are different options. So you do not decide about the management of the patient. Basically, you need to give different management options to the patient. Like for a heavy menstrual bleeding, it may be medical, surgical, conservative, or doing nothing. Okay. So give the plan of management, give the various options, and let the patient choose. Okay. So your idea is to tell the pros and cons of each kind of management and help the patient decide. So don't impose your treatment unless it is something which is life-saving, in which you have to do a particular form of management. In other cases, you offer different kinds of management. Now you should know about a procedure well so that you can counsel about it. So what are the risks and complications associated with the procedure? Knowledge about complications, the background risk, how the complications increase in certain scenarios. Like you may be giving a risk. Suppose a patient has to undergo laparoscopy, and so there is a background risk for laparoscopy, injury to the bowel, bladder, infection, conversion to laparotomy. But if the same patient has high BMI or has multiple surgeries, the risk increases. So it's over and above the background risk. So that is your clinical knowledge, that what conditions will actually increase the risk for the patient. So this all comes under applied clinical knowledge. Now, the last but not the least, is one domain which everybody gets stuck and everybody is very scared of. That is patient safety. So any one of you can just enumerate, what do you understand by patient safety? Again, 45 seconds for this. What do you understand by patient safety? What comes in your mind?
Drug allergies,
Okay.
and to know about her blood group, like if she's negative, Rh negative group like that, or if she's got any specific restrictions to blood transfusions like Jehovah's, and
Okay.
then
Yes.
and uh, that's what I know.
Okay. No problem. So patient safety is something which actually you do on your day-to-day life, in your day-to-day life when you're dealing with patients, but we don't exactly know what is it. So let us see what is patient safety. So actually, when you confirm the patient's name and age, that is also part of patient safety. It's not only communication that you are establishing a rapport, it is patient safety also, that actually you are dealing with the right patient. So that is patient safety. Rightly said, blood group. So one is that you want to know if it's an Rh negative, then you need to give her anti-D, especially in pregnant patients, in antenatal care, maternal medicine, or even in early pregnancy, miscarriages and all. You need to know the blood group of the patient. Drug allergy is very important component for any patient, because whenever you're planning the management, you need to know about the drug allergies. Then patient safety is understanding that this pregnancy is high risk. So all the high risk pregnancy, you understand and you tell the patient that it's a high risk pregnancy, so that you decide that patient is under consultant care, patient needs an MDT, and so on. Okay, or has to, so understanding and then planning management as a high risk case is patient safety. Knowing which drugs can be given during pregnancy and lactation, okay, and which drugs should be contraindicated during pregnancy or lactation, understanding that is also patient safety. Risk, when you are, patient safety is smoking, knowing about smoking, alcohol, obesity, and so because that will increase risk for the patient, or has these patients will have special risk, like smoking in pregnancy can cause intrauterine growth restriction. So this, asking about smoking and then counseling the patient about smoking, patient safety, as I said, high BMI even in pregnancy, or if it's a gynecological case and is about to undergo surgery, knowing the BMI. So you should ask the BMI of the patient. Then thromboprophylaxis. So assessment of the thromboprophylaxis risk, thrombosis risk during pregnancy, and counseling about thromboprophylaxis is again patient safety. In a young patient, confidentiality, advising about safe sex practices, opportunistic screening for sexually transmitted infections is all, and ruling out grooming, sexual abuse is all patient safety. Okay. Then recognizing your limitation, that now you should remember that in the exam you are an ST5 trainee in the UK. So recognizing the limitations of which, how much you can do, calling the consultant at the appropriate time. Then look for hidden agendas like child safety, as I just talked about, and domestic violence. Then hidden agendas in teaching station like bullying. Then risk management in a particular case is all patient safety. In a postpartum case, when you examine the patient, you say, I will just perform hand hygiene, or I'll just wash my hands and then examine you. Patient safety. When you say that I will examine you in the presence of a chaperone, that is also patient safety. So all these things are patient safety points, and there may be many more, but I will advise you to make a note of it and write down somewhere, okay, this is the patient safety point, so that you are not always, trying to find out what is the patient safety point. You should be clear on this. So this was the last domain, which is last but not the least, and this is something which actually flummoxes most of us, and then we are always asking each other, oh, what is patient safety? This all is patient safety. And rightly she said, acceptability of blood transfusion, especially in obstetric cases, if such JO are witnessed, patient safety. Okay. So now, after understanding what are the domains and how one is marked in the exam, we reach the exam now. And before that, I just want to say that when you're talking to the patient, say I rather than we. Only in some situations you try to tell that, you know, you say we as a team will help you, or then you define management as we, but otherwise you should be responsible for the patient. I'm going to examine you, because sometimes the candidate starts speaking like we are going to examine you. So it is take onus and take responsibility for the patient and say I. Okay, so we have reached outside the cubicle and you have 2 minutes. So the 2 minutes, they pass very quickly in the exam. Normally also in an exam, they pass even quicker. So what do you do in these 2 minutes? These are the questions. So what do you do? So you have to you see the name of the patient, age of the patient. So you have to be understanding what kind of patient are you meeting. Try to see what is the main finding in their station. Make your differential diagnosis and write the points which you think you should. Two things you should write. What are the important points you need to ask the patient, and what are the important points you need to tell the patient? Okay. Some of the stations will have multiple papers. You should remember that. And then, you know, you are very scared in the exam, like how am I going to read? It's okay. The question is same for all the candidates who are there. Just try to read through quickly what the station is trying to say. Try to make notes. Okay. Even if you are not able to finish reading completely, or you think you have missed something, the same question is pasted inside on the table, inside the cubicle. So if you missed something, you can go and read there. So if you're going for a structured discussion, so you say that I'm sorry, I was not able to read the question. Can I just go through? And the examiner says, then continue, and then you said that I'm ready for the discussion. On the other hand, if it's a simulated patient task, and you introduce yourself and say that I just want to go through your reports, so please give me 1 minute. And then the role play says, yes, you read through and then start your station. Okay. So what do you think? You should think, where are you? In a station, it will be mentioned you are sitting in the clinic, which may be a gynae clinic or an antenatal clinic, or it's a uro gynec or an onco clinic, or you are in the emergency, or you are in the labor ward. So you think, where are you? Then who are you? Mostly you will be ST5. In some cases, you may be ST4. Then what is the scenario about? It's a postpartum hemorrhage. It's a heavy menstrual bleeding. Understand that. And then how are you going to manage that? So these are the things you see and you do outside the cubicle. So who are you? You are a UK trainee. So you have to think like that. You are the ST5. So you should know the right things. You should know your limitations. Okay. So what the ST5 can do and should not be doing beyond that. Beyond that, you call the consultant or the specialist if it's a multidisciplinary team. So you do not need to do more. So that much you should remember for the exam. Once you go inside the exam, just give me 1 minute. I'll be back in a minute. 1 minute, please. Hello. No, I just, Kamal, I just said that I will be back in a minute. Sorry. Okay, so once you go inside the cubicle, now the actual station starts. So you introduce yourself and you say that I am Dr. Pooja and I'm the ST5 in the clinic or in the emergency on the labor ward today. And check the patient's name and you would ask about the age. And then you set the agenda. So if you got a GP letter, you say that I understand from your GP that you are planning a pregnancy if it's a preconceptual counseling. So you should set the agenda. So you say as I'm meeting you for the first time or before we discuss the management plan, I will ask I want to ask you a few questions. I may need to examine you and offer some blood tests. And after that, I will discuss the management plan with you. I would write back to your GP and give you some written information at the end of the session. Does that sound all right? Is it okay with you? And then she, yes, and then you move forward. Why we speak so much setting the agenda is that sometimes when in 10 minutes you are not able to finish the station, so you are not able to give the written information or talk about PIL later. So at least if you have told this in the agenda, then the examiner knows that, okay, you know what you have to do. Okay, so then ascertain the concern of the patient, knowledge of the patient. So suppose she has a medical problem like an SLE. So she must be knowing already about the disease. So you have to check how much she understands and then what is the starting point of understanding and then go forward. Information gathering has to be structured. So information gathering means you have an organized template of history in your mind. Start with the history of presenting complaint. Okay. So if you're in an obstetric case, you start with the history of presenting complaint and then go on to the obstetric history, current pregnancy, then the past obstetric history, gynecological history, medical history, surgical history, family history, and social history. As in all cases, it has to be always structured like that. Then interpretation of the history, examination, investigation findings, and explanation of the problem. Check for patient understanding. Give the information in chunks. So you have explained something, wait, and then ask, am I clear till now? Or in the beginning also you say that if at any point of time I am not clear, please let me know. Instead of asking, do you understand, it is better to say, am I clear? Because it shifts the onus back to you. Do you understand means that it's kind of patronizing and shifts the onus on the patient to understand. Whereas if you say, am I clear, it shifts the onus on you. So the patient doesn't feel burdened with that expectation. So you say, am I clear? Any questions till now? So that the role player even has a chance to speak. So in between, you should wait. So give information in chunks and stop. Then summarize at the end if you have time and provide information, patient information leaflets and close the session. I'll just discuss the history in some detail after this. Before that, quickly about the history taking. So if a patient comes as an obstetric case, history of presenting complaints, if she's coming with pain in the tummy or pain in the abdomen, labor pain, premature rupture of membranes, or in a gynae case like menorrhagia. So if you say that I understand that you are having pain in the abdomen, I understand that you are having heavy menstrual bleeding. First question should be, can you tell me more about it? That is an open question. So that will give the idea or give the chance for the role player to speak out. Okay, so start with open questions and then go on to the closed questions. If it is a gynae case, always talk about how it is affecting you. So the impact of the problem on the quality of life becomes very important. Okay. If she's a lot of problems, she's I'm suffering a lot, respond to that cue. You should have empathy, and you should be responding and say, I'm sorry to hear that. This is something which you say. If you go on to the obstetric history, history of the present pregnancy, is it a planned pregnancy? Say congratulations if it's not a breaking bad news kind of station. How has the pregnancy been till now? Any problems till now? Have you got done your booking bloods? If the scan is done, you ask about the scan. Is the scan report okay? Are you taking folic acid if you're dealing with the early pregnancy? And then go on to the past obstetric history. So we tend to ask, how many children you have, but that's not a good question to have. The easiest question to ask is, have you been pregnant before? So she says, yes. Can you tell me more about your pregnancy? It should be your next question. So that it is easy and the flow becomes easier. Instead of you asking, have you any children? She may not have any children, but she may have 5 miscarriages earlier. So you say, have you been pregnant before? She says, yes. Can you tell me more about your pregnancy? So that she explains, okay, this was a miscarriage, then I had a normal delivery, and so on. When it's a full-term pregnancy, and she has a child, you ask about the pregnancy, whether there was any problem in the pregnancy, and was the mode of delivery, whether it's a vaginal delivery or a cesarean section. If you're talking about miscarriages, ask whether it was spontaneous or she got it done or it was induced one, and ask whether it was for any personal reason. Okay. Term pregnancy. When you are asking the history of presenting illness in an obstetric case, and it is like a third trimester case, don't forget to ask, are you having any pain in the tummy right now? Are you having any watery discharge? Are you having any bleeding from the vagina? Are you feeling the baby's movements well? We should not forget this. So any third trimester coming, even with other problems, ask about pain, prom, bleeding, and fetal movements. When you're in a case of infertility or subfertility case, if she's planning pregnancy, if she have had any other pregnancy, so she may be a primary infertility, getting subfertility with this partner, but she may have children earlier with some other partner, or if the partner has had any children before with another partner. This is important, especially for NHS funding. So if the patient or the partner has had any children before, even with other partners, they are not funded by the NHS. This is something we should be knowing. Gynae case, can you tell me more of the problem? Then she says, oh, I'm having very heavy bleeding. Then ask more. Then ask close questions. How are your cycles? Are they regular? How many days do you bleed? These are close questions, but they start with open questions. Do you have any bleeding in between menses or any bleeding after sex? So any intermenstrual bleeding or postcoital bleeding? That should be specifically asked. What was the last menstrual period? Using any contraception? Ask about cervical smear. Okay. If she hasn't done the cervical smear, then she has to go. The primary care has to be involved. So the GP has to be told that the pap smear has to be done. Okay. Medical history. Are you on any medication from a GP now or earlier? Are you taking any long-standing medication? If yes, then ask what medication she's taking. Is she following regularly with the GP or the physician? And whether the gut disease is under control. Specific histories, like if you're talking about oral contraceptive pills, so you need to know about DVT. So is there any history in you or in your family of any clots in the legs or the lungs? And would you accept blood transfusion as in obstetric cases to rule out Jehovah's Witnesses? Family history, any family history which is significant, and then surgical history also. Have you had any surgery in the tummy or down below is what we are bothered about. Family history of any significance. Social history, what do you do for a living? Assessing the support of the patient is important, especially in the vulnerable population. So do you have adequate support? Everything, whom do you live with is a simple question. So she will tell about her family, she lives with a partner or children or whatever. And everything okay at home? I think some people ask, is your partner supportive and all, but it's a very offensive kind of question. So better to ask, everything okay at home? That's more benign as a question. Then about addictions, you should say that I want to ask you some personal questions. These might sound intrusive, but I asked from all of my patients because that has a bearing on your management plan. Is that okay with you? Offer that and then ask if it's okay. She says yes. Then, do you smoke or take alcohol or any recreational drugs? If she says yes to any, then you go further. If she says smoking, yes to smoking, how many cigarettes per day and since how long? Have you ever thought about quitting? If she says yes, I have not been able to, then you offer NHS stop smoking services. Then there are NHS drug and alcohol services if there is any other addiction, and so on, so that you offer. Okay. If she's pregnant and smoking, you say that I'm not trying to be judgmental, but are you aware that smoking can be harmful in pregnancy? If she says no, then say that it can cause harm to the baby and to you. It can cause growth restriction and stuff. So talk in that manner. Then allergies. And if she says, yes, I have allergy to her drug, say what kind of allergy? Did she have only rash or she had something very serious, something like a angioedema? And then I say, I will write back to your GP about your care plan. I'll give you some patient information leaflets, tell about the website, support groups. Okay. And then if you are fixing another appointment, say I will fix an appointment with the consultant for your next visit. If she has not come with a partner, wants to discuss with the partner, say that I'll fix an appointment with your partner so that we can discuss it further in the next visit. Okay. In the end, if you have taken the history, you just say that anything you want to add, anything else would you like me to know, and so on. The examination, you say that I would like to examine you in the presence of chaperone because I'll examine you vaginally and I want to look at the size of the uterus and the ovaries. Then tests also you justify, discuss the care plan. You will be under consultant-led care, okay? Or you will be under shared care between consultant and midwife. You will have more visits than usual. Or if it's a urogynecist, you say that your plan will be discussed within the multidisciplinary team constituting the gynecologist, the urogynecologist, the incontinence nurse. So when you talk about multidisciplinary team, tell about the members of that team. Okay. If it's a mental health problem, say I will refer you to a perinatal mental health specialist. Okay. Then you can give contact in the end of the key workers or the specialist nurses, so where she can contact. So this is about what do you do inside the cubicle. Now, the key to the exam, which everyone should understand, is the communication skills. Communication skills are being tested in the 3 domains. In the information gathering also, how you are asking the information, the sensitive information, communication with patient, and communication with colleagues. So all these 3 domains test your communication skills. So you should understand that it's very important. When you're communicating with the patient, the role player, you listen first, allow them to speak. Your voice should be calm, low, and firm. You should have empathy. You should acknowledge the emotions of the patient. The patient says, oh, doctor, I'm feeling a lot of pain. Be empathetic. I'm sorry to hear that. I can see that you are in a lot of pain. I can see that you are very angry in case of anguish. Acknowledge those emotions. Non-verbal communications, how you're sitting, how's your demeanor, your body language. Combination of open and closed questions. Always start with open question and then go to closed questions. Targeted history. Give a simple explanation. Avoid the medical jargon. Information in chunks and check the understanding. Be honest. Follow duty of candor and apologize when relevant. And that is not an admission of the guilt. Now, how do we prepare for the course, for the exam? So you have study material, you have courses, and you prepare with colleagues. And all of these have their own importance. Preparation with colleagues is very important because generally if you have a study buddy or a study partner, it is easier. You can give, do more and more stations and give feedback. And what you require is practice. So the study material is same as part 2 plus the books. So guidelines, PILs, patient information leaflets, talk articles, books. The first book you should start with is the Part 3 Mrcog Essential Revision Guide by Lisa Joels and Edmund Neal. Then tasks for Part 3 Mrcog Clinical Assessment by Mukhopadhyay and Sule. This is an Oxford task book, which is a very good book. So after Lisa Joels, you should start that. It has got 70-80 stations and very good explanations, very wide variety of stations. Get through Mrcog Part 2 by Justin Clark and Kumaraswamy. This is a 2018 edition of this. It tells you very nice lines about what to speak in various scenarios with the patient. And then Tony Hollingworth, OSCE for Mrcog Part 2 Self-Assessment Guide. It's a very good book, especially for structured discussion. Some sticky scenarios that may come to you are hidden agenda, like domestic abuse and bullying, angry patient or relative, complaints, complication in surgery, breaking bad news, dealing with young adults, and HFEA guidelines. So this I've already discussed. Now let's look at the May 2020 exam. So there are 7 months to go, okay, starting December. So you require a strategic preparation, and you have to divide your time wisely, as I said earlier. Divide into 5 months and 2 months. The initial preparation months generally are with the course, and then self-preparation. So let's talk about a little about the course before I go on to the station. So how we can prepare with the course or study with the course. The course is starting in December. So the course will go on from December, January, February, and a part of March also. How do you study? So in the course, you'll be knowing which module you are doing in the coming week. So make a template for each module. Write down as many as different stations as you can. Write down special lines you want to speak in a particular station. Watch the relevant videos to the same module from different books to strategy selectively. Write the queries and point of confusion and ask during the course. And we are also going to have a Telegram group in which you can put your queries. During the session in the course, either you will be presenting the station or listening. Listening also has to be an active listening. Sit with paper and pencil, not the pen. Why I say pencil is because you get pencil in the exam. You get a notepad and a pencil in the exam. So you should be used to writing with that. So even if you're not presenting, the other candidate is presenting, those 2 minutes, think that you are in the exam and you are standing outside the cubicle for those 2 minutes. Listen to the candidate, write down to the points made, okay, and missed by the candidate. So you should critically analyze the other person who's speaking. This helps you to improve your own performance. Listen to the feedback given by the mentor and given by the other candidates and write the points about theory and communication. After the session, you should complete your notes, write down the important points, the practice speaking aloud with a friend, and start preparing the next notebook. You should write as many stations as you can, and you should have a dedicated notebook for that. April and May, revise your notes, revise the relevant guidelines, especially for structured discussions. Spend some time to read clinical governance. You all know that clinical governance is something the overseas candidates have a problem dealing with. So always you should revise, audit, risk management, and so on. And keep practicing stations with your friends daily, at least twice a week maybe. Give honest feedback and be ready for bad feedback. Repeat, repeat, and repeat. And May comes the exam. Okay. Again, I told you about this problem that simulated patient tasks, candidates are able to do okay, but there's difficulty in structured discussion, so we'll deal with this problem in the course. So now I'm going to do the 2 sessions which I've prepared for you. And those who want to volunteer for the stations, put your names in the chat, and I'm going to start in a minute. Hi, somebody has to volunteer for the stations. I can't do them alone. Okay, till the time people are getting ready to volunteer. I know it's scary to actually present a station in front of so many other people, but it's okay. It's just the beginning, and even if you're not able to do well, it's okay, because this tells you where you are at the beginning of your preparation, and with repeated practice, you are definitely going to become better. I hope somebody will volunteer on the chat for the two stations, because I cannot do them alone. I cannot do the station. I can just be the role player and then give the feedback. Till the time somebody volunteers, I would talk about the course. So this course is the comprehensive extensive course, which we started later on. We have been doing 1 month courses from August, as I said. The first comprehensive extended course was in June, and this is going to be the second one for the May 2020 exam. The duration is going to be 3 to 3.5 months from December, as I told, maybe mid-March. There are going to be 18 stations in this course. One station will be the introduction, and we will be doing the miscellaneous stations, which is a very important session in the sense that these miscellaneous stations are the different and the typical stations which pop up in the exam. Many actually belong to the clinical governance side or emergency. Then there are 14 sessions in which each module has a separate session for itself. So that session will be dedicated for that module. In each session on each module, we tell about what are the various stations possible in that module, a generalized template for that module, and do important stations for that module. Then there will be one session on structured discussion. So only structured discussion stations in this session. Please remember the other stations will also have structured discussion, but we want to have a dedicated session for structured discussions, because many candidates, they feel scared, or they have a problem in doing these kind of stations. Then there are 2 lecture-based sessions on difficult topics in Mrcog. I'm going to talk about what difficult topics we talk about. The sessions are weekly, so that you get ample time, at least 4-5 days, to prepare well for a particular module. So P will be your study buddies for this course duration. So in a session, a template for each module will be given. High yield live stations will be used. So we choose the stations. We have a meeting in the beginning of the course between the mentors. So you all must be knowing, I am Dr. Pooja Sharma Dimri. I am one of the mentors for this course. The other mentors are Dr. Sidra Ali, who has been taking part 2 courses, and many of you may be knowing her. Many of you definitely are knowing him. And third is Dr. Muhammad Hassan, who's again has been teaching a lot of candidates for part 2 and part 3, and he also does on-site courses in Egypt. So we are the 3 mentors. So before the beginning of the course, we have a meeting to discuss the stations. We decide the stations so that there is no overlap, the stations, so that you get 80 total stations in the course, which are different from each other. We see what the type of stations are coming in the recent and the past exams. So all the stations will be based on those, so that you don't miss the important stations. We give you ample practice on difficult stations like audit, risk management, angry patient, breaking bad news, and hidden agendas. We simulate exam scenario, so we actually bring a bell and give you 2 minutes reading time and 10 minutes time for the station. And then after the station is done, the mentor will give feedback to the candidate participant, and then discussion will be done. Now, and then we also try to give a list of other important stations in the module you should be practicing at home. Now, I, for one, when the candidate presents, I invite one of the other candidates or the listeners to actually give feedback. So when you critically analyze another person's performance, it's not to bring the other person down, it's just to analyze and to have a better understanding of how the things can be, and that improves your understanding of the station very well. So, and then I give the feedback in the end. So it is like a two-way session. So there's a lot of interaction, and other people can always comment and add points. So we do it together. Now the difficult topic discussions, there are two sessions. One will be taken by myself, second by Dr. Sidra. That involves, so this is a list of the difficult topics which we'll be doing in those two sessions, but this list is not exhaustive. We keep on adding other topics. So the topics are angry patients or complaints procedure in the UK, dealing with young adults, sexual assault, mental capacity, breaking bad news, abortion laws in the UK, HFEA guidelines, bullying undermining in workplace, vulnerable populations, complications in surgery, confidentiality, when you don't know anything about the station, disagreement between doctor and patient, labor ward prioritization, and gynae list prioritization. The simple steps to high score are: focus on what matters, pay attention to the detail, listen more and talk less, and use the role play to your advantage and stay confident. So this is the main idea about what a comprehensive extended course. So it will be from December to March. You will receive the recordings of each session. So if anyone is not able to attend a session because of some personal issues or because you're on call or on duty that day, you can definitely listen to the recording the next day. And the recordings are available for 2 months after the course. So till the exam, you have access to the recording so that you can listen in again and analyze and you note the points. Okay. So you'll be doing 80 sessions in the course plus the 2 stations I'm going to do today. Fine. Before we reach the end of the session, okay, Divya Lakshmi has kindly agreed to do the first station. So I'm going to that. In the meantime, I want another candidate for the second station so that we can finish fast, because if nobody has volunteered, I have to move forward because it's quite late at my end now. So another person should volunteer. So now I will be giving 2 minutes for reading the station and then 10 minutes for the action station. Lakshmi, you there?
Hello, ma'am. Yeah, I'm here.
Okay. Okay, so setting the timer for 2 minutes and your time starts now.
Thank you, ma'am.
Okay. Your 10 minutes start now.
Okay, ma'am. Um, hello. Hello, Miss Diane. Myself, Divya Lakshmi. I am the ST5 in Gynec Clinic today.
Okay. Hello, doctor.
Hello. How would you like me to call you?
You can call me Diane.
Okay, Diane. Uh, so I can understand that from the GP letter that you have had a spontaneous miscarriage recently, and you were also admitted for evacuation of the retained products. And there has also been the histopathology report. Are you aware of that report?
No, doctor. This GB told me to come and talk to you about the report, so I want to know what it is about.
Okay, okay. That's why we are here for the discussion. So the histopathology report says that you have had that pregnancy is not a normal one. I will explain about it. A
Not
normal
normal.
pregnancy. Yeah,
I thought it was okay, and then I miscarried.
I'm sorry to tell about this, Miss Diane. And, let me explain about it. A normal pregnancy has the baby developing along with the afterbirth. But in this kind of pregnancy, it's only the afterbirth developing without a proper baby getting formed.
So what is that, doctor? Why does it happen? Like how it happened to me?
Okay, it can happen to anyone, Miss Diane. It's not that it's your that it's because of your guilt. You not feel guilty about it. It can happen to anyone. It is basically a genetic problem. Uh, am I clear till now?
No, doctor, I'm not able to understand. Like what is it? What has happened and why like this happened?
Yes.
I was told it is just a miscarriage, and I thought okay, but I was
Okay.
trying for pregnancy, but
Okay.
now you're telling that it was something very abnormal.
Yeah, yes, I can understand your concerns, Miss Diane. So this kind of pregnancy, a normal pregnancy results because from the chromosomes getting combination of chromosomes from the mother as well as the father. Normally, a baby will get one set of chromosome from the mother and another from the father. And this in this type of pregnancy, there is an added set of chromosomes. So there is it's not a normal one. So that's only the afterbirth is getting developed in the womb. Um, am I clear till now?
Okay.
Okay. So
But now it is miscarried and you have already removed it, isn't it?
yes, yes, it has already been removed, Ms. Diane. So I will ask you some relevant questions. Later, I will suggest you the necessary investigations, and I will suggest you I will discuss with you the necessary management plan. Is that okay with you?
Okay.
Okay, okay. So can you tell me in detail about your pregnancy? How did you confirm it, and so on?
So, doctor, actually, my periods have been irregular. So
Okay,
my period got very delayed, and I just uh, did a home pregnancy test. It was positive,
okay,
and I thought it was very welcome pregnancy for me. But then one day
okay,
I started bleeding, and I started blood passing clots. I came to the A&E, and then they said that I'm already miscarrying, and
okay,
I should come back. The bleeding had become less, so I went back home.
Okay.
Once I came, they again saw I kept on bleeding little bit, and then they said that the miscarriage is not complete, and
Okay.
I had a bout of heavy bleeding again, and I lost a
Okay.
lot of blood. I was feeling very dizzy, and then they said I have to get an evacuation done. And then
Okay.
once they did it, then after that the bleeding was controlled.
Okay.
I don't know what happened, but I just did the urine pregnancy test.
Okay. Okay. So I can understand how it must have been traumatic for you. I can understand your concerns, Diane. So, have you been pregnant before? Is this the first pregnancy?
No, this was my first pregnancy.
Okay, okay, Diane. Okay. Do you have any relevant medical conditions? Like, are you following your GP for any particular medical condition? Are you on any long-term medicines?
No, doctor.
Okay. Have you done any surgery before, Diane?
No, doctor.
Okay, okay. Do you have any drug allergies?
No.
Okay, okay. I will ask you about a little bit of your social habits. This is necessary for my data collection. So, do you smoke, Diane?
No, doctor.
Okay. Do you consume alcohol?
Once in a while in social gatherings.
Okay, okay. Any history of any recreational drugs?
No, doctor.
Okay, okay, fine. Are you aware of your BMI?
The GP said it was 30.
30. Okay, okay. So how is your support at home?
It's good. I live with my husband.
Fine, fine, Diane, fine. Okay. Um, so right now, do you have any complaints? Do you have any bleeding?
There was some spotting after the DNC they did, but after that it's okay.
Fine. Okay, okay. So coming to the discussion about this condition and the management plan. So you have been the procedure has been done completely. So you not worry about it. The histopathology report says the condition that I explained before. So this particular condition requires a follow-up. So it means we need to take a blood test from you. It's a measurement of the pregnancy hormone. It's called the beta HCG, which should be done irregularly, like every 1 or 2 weeks. And what we are going to see in that is that we will check whether it is decreasing. Normally, after any pregnancy event, this particular hormone will decrease and becomes normal in maximum 6 weeks, 6 to 8 weeks. So we need to check that it returns normal in that period. Because this particular condition it has got a complication that is it's a very rare one. It can proceed on to persistence of the that tissue. Um, Persistence of this condition. By checking the blood test, we can confirm whether it is completely come to normal status.
Okay.
Clear, Ryan?
So what are the problems this kind of pregnancy can have? You said, what are the problems it can have?
Yes, yes. So coming to the problems, there are two different types of this particular pregnancy. We say it is a partial molar pregnancy and a complete one. So your histopathology shows it's a complete one. So this has got a minimal chance of becoming a getting into a condition that is it's a persistent molar pregnancy. It's a it's a cancer, it's a malignant condition, which means that it can persist
Okay,
in your
stop.
womb.
Okay.
Sorry, I
Divya,
got
sorry, your time's up.
thought block. So sorry.
No, you don't have to apologize for that. I know it's the beginning of your preparation. So how do
Yes,
you
ma'am.
feel about it? It's a very straightforward case in the sense of molar pregnancy.
Yes, ma'am.
So, but yes, still you find that there is so much of difficulty in speaking when you start speaking, isn't it?
Yes, ma'am. I particularly suffer from this thought block, so I. So,
So it's okay because you are presenting in front of so many people. Uh,
yes, ma'am.
so if I see, if you say domain-wise, communication with patient was okay because I think you were empathetic. You did respond, and to something. Okay, I'm sorry to see that this has happened. That this is the abnormal pregnancy.
Okay.
Tone and talking wise, okay.
Okay.
Overall communication with the patient not bad for the beginning.
Okay.
There were a lot of pauses from your side, so
Yes,
uh,
ma'am.
so you have to say something for the role player for her to speak. But I think that was, you said, thought block because you just stopped
Okay.
speaking, and the role player, and then the third time you said, okay, am I clear till now, so that the patient can speak something, but in between you just stopped and there was no communication in between.
Okay.
In the beginning, you said that hello Diane, and then you said how can I address you. You already addressed her as Diane, so
Okay.
uh,
Okay, ma'am.
if you have decided to address her as Diane, so you say, okay, is it Miss Diane Keaton, or is it or Diane? Hello, I am Dr. Divya Lakshmi. So that you've decided. If you say her
Okay.
full name and then you say, you mean what, you understand what I'm saying. So then you can, either you're saying
Yes,
her
yes.
full name and then you ask her how she wants to be addressed.
Okay, okay.
That's
I
a small
understand.
thing. Yeah. Uh, then setting of the agenda was again haphazard because you said that, okay, I understand from a GP letter that you had a spontaneous miscarriage, and then later you said that I'm going to ask you questions. Then you started explaining about the molar pregnancy was, and then you said I'm going to ask you questions, and I will write back to your GP and all that. So that was like half. So when you're
Okay.
setting the agenda, you say in the beginning, okay, I understand that you have spontaneous miscarriage, and you're here to discuss your report. Do you know anything about the report? It's fine that you said that. She says no.
Yes.
So you can say that. Do you mind if I ask you a few questions, and I may need to
Mm,
examine you, and then we
mm,
will discuss the care plan, and I will write back to your GP regarding that. Is that okay with you? And then you continue.
mm,
So it was
mm.
overall, I think it was a little disorganized because again, it's the beginning. You need to know the things. This is, I'm going to ask this, and after this, and then it should come very reflexively to you. Then you said, I will ask you relevant questions. So this relevant word is not to be spoken to the patient. That is for you. That you are asking
Okay.
relevant questions. So just say that I'm going to ask you a few questions. Uh,
Okay.
then basically, social history, who lives with you, and what she's working as, and okay, rest. I think you asked what allergies. Asked
Mm,
there. You need to ask for the blood group also. Even it's a complete molar, though this is a diagnosed molar, sometimes it is only on ultrasound and not don't have the histopathological diagnosis, that you need
mm.
to think about anti-D if it is an Rh negative. Uh,
Okay.
so I think mostly it was the information gathering was haphazard, and that is why the patient also becomes. And then you asked about the pregnancy. So you were asking, and then you said, how, tell me more about this pregnancy, whatever. So it was, again, it came back later. So I think you were asking as you were remembering, but that was not in sequence, is what I felt.
Okay, ma'am. Okay.
Yeah. So, and then have you been pregnant before? This was all like,
Mm.
basically it was not organized as a history should be. Because if you organize it, then it is for the other person who's listening also, and for the examiner also, it's easier to understand.
And, how
The
can I ask
explanation
about
about
about her pregnancy score? Whether this is a first pregnancy or how should I ask that? When should I ask that?
so actually, again, you always start with the history of presenting complaint. So history of presenting complaint is that she has a miscarriage and is coming with her
Okay.
report. So that you did
Okay.
ask, okay, so can you tell me more about the pregnancy? What happened? Can you tell me about the events? And she says, I had this, and yes, because you need to know whether it was confirmed by ultrasound. So she says that I just had the pregnancy, and she bled, and then they did evacuation. So that is this pregnancy. Then you can ask more about this. After that, you said that have you been pregnant before? Simple as that.
Before.
So after the present pregnancy comes the obstetric history. They said, have you been pregnant? Because you want to know she has a molar earlier, whether she had a normal pregnancy or it's a first pregnancy. So simple as that. So any antenatal case, history of presenting complaint is always there, whether antenatal or gynae. And after that, the past obstetric is, have you been pregnant before? If she says yes, you need to know the details of the pregnancy. If she is no, well and good. So this time the patient says, no, this is my first pregnancy. So it's simple. Just ask, have you been pregnant before? Okay. And then carry on. And then you said again, relevant medical condition. What do you mean by relevant medical condition?
Okay.
There's nothing relevant. Any medical condition is important for you.
Any medical
condition. So you say that if you know any relevant medical condition, you should be asking specifically about that as a next question. But as a generalized thing, you say, have you been under treatment from a GP or earlier, any long-standing medication, and then go on to the surgical history. And then again the social history then.
Okay.
Then the patient also says that she was looking forward to the pregnancy and it has miscarried. So you should offer, yeah, I'm sorry to hear that. How are you coping with it? This is something you should ask, because she wants pregnancy, but she has a miscarriage. So how are you coping? So she may be under depression. So depression may be a hidden agenda in these kind of cases. So it should actually, so one is that the role player will give you indication in the mannerism and all, and then you have to ask, have you been feeling low about it? How have you been coping? If she says yes, it was difficult, now it is okay, it's fine. This is I feel very bad or something. Then do you think more support will help? If she says yes, I'm not able to cope, then you have to follow through. Follow through will be, do you think more support will help? If she says yes, I can refer you to a counseling service, would help you to deal with the situation better. Is that okay with you? So offer that. So if he says no, yeah, I'm okay, I've been coping, it's fine. If he says no, yeah, I'm very sad and I don't know why it happened, and this is you. Do you think more support will help? And then offer that. So these are the basically things in communication. Applied clinical knowledge, again, you need to actually read the guidelines. Some things I think you did not remember is that first is that you register them in as far as whenever the molar pregnancy is concerned. So you do explain. You can use a diagram to explain her. So and then you ask this later. How are you now? So that should also come initially. When you say that I understand that you have had a miscarriage, and then this thing. I ask you more questions. Then you say that how are you feeling now? Any bleeding now? Any fever? Any dirty discharge? You have to talk about infection, any heavy bleeding, any fever, isn't it? Any patient who comes after the casual ask this thing, and how's the bleeding now? So that should come under the history of presenting complaint. And then definitely, if she says it's a plan going, how are you coping with it? Okay. So any pain, any bleeding, any fever, any abnormal discharge, and how is her mental status at that point? This should come in the history of presenting illness. And then you can explain that it is, I'm sorry to tell you, this was not a normal pregnancy. And then you must explain that, so this station also can come as that patient comes with the ultrasound report of vulvar pregnancy. Then you have to break the bad news. So this station is not typically break the bad news, that already she has had a miscarriage. And that was a break bad news in this case. But now she's here to discuss the report. It's bad news in the sense that it's not a normal pregnancy. She requires a longer follow-up, but not the typical. But it can also come as a ultrasound report of molar pregnancy. which will be like a breaking bad news. Okay, and then you say that tell about the mole. Okay, this is not a normal pregnancy in which only the afterbirth is there. This is due to a defect when the embryo forms, and a single sperm fertilizes an egg which is empty, which does not have any genetic material. So then the pregnancy cannot develop further, and it is abnormal. Okay, so and then the histopathology is already available, so you know that since it is not a normal pregnancy, sometimes it can lead to persistent, and it can lead to cancer also. You did not use the word cancer, is what I remember.
Yes.
Yeah, so you have to talk about choriocarcinoma also, that you have to emphasize that this condition requires a long follow-up for her. So you have to explain why. So you say that it can be a persistent in which the pregnancy hormone remains elevated and patient can bleed again and again, or it can sometimes even lead to cancer. So we need to follow you up for a longer time. She will be registered under a specialized center. So you should remember that all the molar pregnancies in UK will go to one of the 3 specialized centers, which are in London, Sheffield, and Dundee. Okay, and the pregnancy hormone, which is the beta HCG, will be followed up in the blood or urine. So basically, the specialist center with which she is registered, okay, posts the kit to the patient, which is done at the GP surgery or a local hospital. So the center, all the patients are registered there. The center,
I didn't get you again.
So what happens is patient gets registered at the molar pregnancy center, okay, the specialized center.
Okay.
The specialized center, as a follow-up, will keep sending the kits, either it's a blood or a urine kit, goes to the local hospital or the GP, where the patient can reach, and she gives the sample. Okay. Yeah. So the monitoring or the control is done at the specialized center level, but the blood sample is taken at the local level. Okay, but the monitoring is at that level. So you can say that if the pregnancy hormone returns to normal in 8 weeks, that is 56 days, then you have to provide the blood and urine sample for 6 more months. But if it is delayed, it is 6 months after normalization. And you say that if there is a persistent problem, which is called as the gestational trophoblastic neoplasia or persistent gestational trophoblastic disease, then the one person may require some drugs which are chemotherapy. So will require chemotherapy, and the cure rate is very high. So that you should say, okay. And then you say, and then you talk about contraception. That's very important. This is until the levels become normal, and we need to, you should not get pregnant, because again it will interfere with the values and we are not able to follow up. So you have to talk about contraception. You have to talk about next pregnancy. So in next pregnancy, whenever you miss your period, you should contact the hospital immediately, so that an early scan can be done for you. So you have to always complete the cycle. Okay, so you talk about the next pregnancy. And any pregnancy after its completion, the specialist center will be contacted 6 to 8 weeks after any next pregnancy, and beta HCG levels will be done. And that's it. And then you say that in between, if you have any heavy, you should also give when she should come back. So you say that if you have any heavy bleeding, any pain in the tummy, or you have fever and all, you should call us and come back immediately, because she just has the miscarriage. The beta HCG is going to be high. She may bleed and all. So you should tell her that these are the warning symptoms she should think of before she comes back. So it's a very straightforward thing. The only thing you have to tell her is a molar. What is the molar? It will require follow-up, because the evacuation has already been done in this case. It can lead to persistent disease, or it can lead to cancer. There has to be a registered center. She has to be registered there, which will actually monitor the follow-up of the patient. She requires contraception and monitoring even in the next pregnancy. So these are the points of applied clinical knowledge. Okay. Do you feel better now and understood where we can improve on this?
Yes, ma'am. Yes, ma'am.
So it's okay. It's okay. When you begin, I think it's a brave thing to actually volunteer and come forward. So it's fine. It will always
Thank
be
you,
done
ma'am.
like this. As you practice more and more, you will keep getting better and better. So that's the natural progression of the preparation. Okay. Thank you so much.
Thanks a lot, ma'am. Thanks a lot, ma'am.
Thank you. Okay. Bhagirathi has kindly offered to volunteer. Hi, Bhagirathi.
Hello, ma'am.
I welcome to this session.
Hello. Thank you.
So actually, you are getting a difficult case, which is technically difficult, but it's okay. I generally keep one of the difficult cases in the first session, so that when you tackle that case, then the easier ones become difficult. So don't worry
Okay,
about
ma'am.
it. Okay?
I'll try my best.
Yeah, of course. It's okay. It's just a trial session today. Okay. Okay. So
Okay,
your 2 minutes start now. Okay. Your 10 minutes start now.
Okay, ma'am. Hello, I'm Dr. Bhagirathi here. I'm ST5 in Gynae Clinic today. Are you Miss Diane?
Yes, doctor, I'm Diane.
Okay. Diane, what happened? Can you tell me more about your problem?
Yeah, doctor. So actually, I went to the GP, and then he asked me to come to you. I am 16, and my lower down, the labia, what you call, is very big. It's abnormal. So when I saw some photographs on the internet, and when I saw my own thing down there, I think I'm very abnormal, and this is giving me so much of anxiety, and I want you to do a surgery on me.
Okay. See, did somebody tell you that it is big, or did you just find it out yourself?
No, I saw, because I used to think that that it's little big, but when I went to the internet and I saw those images, then this is really, really abnormal.
Okay. Do you think that it is growing in size, or like it has been like this from the beginning?
Well, it may have grown in size, but not too much. But I really noticed it very well now, recently.
Okay. Is there any pain, redness?
No.
Okay. And what about your periods? Do you get it regularly?
Yeah, periods have always been regular, doctor.
Uh, is there pain during periods, or is it like normal?
Little bit pain, but not much.
Is there any dirty discharge?
No, doctor.
And smell? How is the smell?
Mm, as usual.
Okay. Uh, and when did you start getting periods?
When I was 13 years old.
Okay. Can I just ask you a personal question? It's important for me. Are you
Yeah, sure,
sexually
doctor.
active?
Uh, no, doctor, no, because I think uh, my boyfriend would not like it. What I look like down there.
Okay. Who are you staying with your parents?
Yes, I stay with my mother.
Okay. Okay. Um, okay. What? Can I ask you some other questions? Like, if you don't mind, I'll just ask you some personal questions. Um,
Yeah, sure, doctor.
do you smoke?
No,
Okay. What about alcohol?
no, doctor, never.
Okay. Have you had any surgeries in the in your in the when you were child? I mean, you had any operations or any surgeries done in the below the below part?
No, doctor.
Okay. Do you have any pain while passing urine
No,
and any problem for passing motion?
no, doctor.
Okay. See, I understand that you've been like checking the internet and but have you shown before that? Have you discussed this with your mother or like you know, or is it just the knowledge from the internet?
See, it is very difficult to discuss these things with your mother, doctor, actually. So
Mm-hmm.
I just told my mother I had some problem and I went to my GP, and you're the second person I'm telling this.
Did your GP examine you?
He saw and he didn't think anything was abnormal in that. He said it looks okay, but
Oh, is it?
better you. But then I told him that it doesn't look okay to me, so he said you meet the gynecologist.
Okay, because what I understand is from internet, whatever information you get is not accurate because no, that can be different variations of normal. The normal, the labia, the so internet information is not always accurate. It's always better to check it with the doctor or no, with the elders. So,
Okay.
but then as you said, from what you are saying, I mean, there's no pain. Otherwise, you don't have any other problem with your periods, and there's no smelly discharge and your GP has already examined you and he's thinking that it is probably normal. So I would, if you want, I can examine you one more time with the help in front of a chaperone just to make sure that I mean you're okay. Is that all right with you?
Okay.
Okay, then shall I examine you now?
Yeah. So examination is all okay. Carry on.
Okay, 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 fine. So from what I can see, it looks normal to me. And as I said before, like see what you see in the internet, it may not be always correct because as you always know, no, the internet they put the pictures of models or or something like that. So it may not be the exact um, look of how because different people will have like there are different variations to normal. So. mm so I would I mean I and like if you're not really convinced I can refer you to a consultant also who can also have a look at you and we can do some scans if you're really worried to see if inside everything is okay your parts and all that but
I'm not worried
or
about the inside, doctor. It's the outside I'm worried about because I think I need a surgery.
see because surgery itself there are a lot of complications for surgery is not very straightforward for these kind of surgery, see the surgery itself, you are saying to reduce the size, no? There can be scars after that. You can have pain. Sometimes you get infection after that, which may even worsen the look of the area. You get scars there. And sometimes you can get infected after the surgery. There can be bleeding. So option for something which is probably normal. So I would like to think twice, before doing some cosmetic surgery or something like that, for something which is normal. Uh, do you
But
have before? Do you have any other fears or any other?
my fear is that I can't have a boyfriend, doctor. That's the biggest fear I have.
But but see, everyone, I have examined you. The GP has examined you. It looks normal. You don't have any other menstrual problem, any other pain. So why do you think the boyfriend may not like it? It is just a variation of normal. So if you want, I can send you to a counselor also who can also talk to you regarding this, a midwife.
Hello.
See, you have to. I think it is just the fear of like being abnormal, but it is normal. You can talk.
I can't
Hello.
hear you. Yeah, your voice was cracking. Yeah.
Oh, sorry. I another call. I'm sorry. I was just getting another call. Uh,
Carry
so
on.
if you're worried, if we can refer you to a counselor also who can also talk to you regarding this, and that will give you another opinion. So, hello.
Hello.
Yeah, am I audible?
Yeah. Carry on. In between it was going.
Yeah, yeah. So, do you want me to refer you to a counselor or a consultant?
No, doctor. Can I get it done in private?
The surgery.
Yeah.
Uh, that's what I said. I don't think a surgery is indicated for you at present because no, the complications are worse than not having a surgery. So as I said, you can have infection, you can have a problem, you can have a scar, which so you before having it, I think you can, if you want to have one more discussion, I can refer you to my consultant and he can talk to you again, and maybe you can discuss with your mother also.
Okay.
Yeah. Okay.
Okay, doctor. So, what next?
Yeah. So, do you want me to refer you to a counselor, Diane?
No, doctor.
Okay, okay. So, or do you want me to refer you to a consultant or something? No.
Yeah, sure. Because I think I need surgery.
Yeah, you can talk to the consultant also. I'll
Okay.
refer you to a doctor. But then I can send you some, I mean, some information
Time is up. Time is up.
regarding this
Time is
because
up.
yeah.
Time is
Thank
up.
you,
You have
thank
to
you,
move to the next cubicle now in the exam.
thank you, thank you. Thanks a lot.
So, how was it,
Okay.
Bhagirathi?
I mean, I didn't know really what to.
Hello.
Hello, sorry, I didn't really know what to tell. I was just blabbering something.
Yeah, it's difficult. I agree. I told you in the beginning, this station is not. It's not an easy station. So let us go one by one.
Okay.
So uh, communication with the patient. Okay. Uh, but you need to be more responsive to what she's saying. She said, "I'm very in the beginning." She says, "I'm very anxious about it." You just said, "Okay."
Okay.
So you have to one mirror the emotions and say that I'm sorry to see that you're so anxious about it. Uh,
Okay.
let me ask you a few questions and then we can discuss the care plan together. Is that okay? So you have to respond to the patient's emotions. That is important. Uh,
Okay.
then what more I have written? I'm not understanding my handwriting. One second. Yeah. Okay. So then the good things you asked about you ruled out some infections like whether it has been increasing too rapidly. Then you said pain, tenderness, any discharge. So she can have STI. Uh, then okay to take history of female genital mutilation. Unlikely because normally they will give you some other hint, but it's okay. Then when you ask about female genital mutilation, it is not a surgery. So you say that have you at any point of time in your childhood have you been cut down below is what you ask. So it's not a surgery. Okay.
Okay, okay,
Uh,
okay, okay.
yeah, uh, and then you asked about whether that was a good thing to ask whether somebody has told you or you yourself feel that it is abnormal. That's one thing. Somebody is grooming and any sexual assault or any sexual problems you have to rule out. You asked about so when you said that can I ask you a personal question, and before she replied you started asking the personal question actually.
Yeah, yeah.
Yeah, so
Okay,
you when you ask a question you have to give the time for the person to speak. Otherwise, there's
okay,
no
okay,
point of asking the question. So you said when you were asking about the sexual activity, you said, "Can I ask you a personal question or a sensitive question?" She said before she said yes, you start asking, "Are you sexually active?" So avoid that because that is important in communication with patients. You please remember this kind
okay,
of stations are the one where the lay examiner also will be sitting definitely. So these stations are like very high marks because the lay examiner is also marking you on the same thing. Uh, then you have to so patient safety wise okay because you did ask whether anybody has told, so that is one of the points in patient safety, which is, and then sexually transmitted diseases and all. Social history, again you said whom do you live with, or she says I live with my mother, but social history you have to ask because she's a young adult you have to ask about what are they doing, like they are in school or not, what grade she is in, and everything okay at school. So
okay,
this
okay,
so this is a part of social history in this case because in an older patient you ask, so she's basically working and does she have adequate finances support? Here she lives with the mother, but what is she doing? Whether she
okay,
is studying in school, she's a dropout. That tells you it's a vulnerable population or not. So if she's a dropout from school, not doing well in school, so she may have other issues. She have more psychological problems
okay,
than you uh, are now evident. So so this social history in young adults is important. Then you asked about smoking, alcohol, recreational drugs also you should ask because they may be exposed to that. So she has come
okay.
for a labiaplasty and everything is normal. So what other things you have to tell this case? So so now before we start, when you see this patient in the 2 minutes, you should what should we think is she is 16-year-old, so she's a young adult.
Mm.
Okay. So you have to have the issues which you need to think about is the confidentiality. So you should assure confidentiality. So that I'm going to ask you a few questions, uh, and I may need to examine you and order some tests, and then we'll discuss the care plan. I must tell you whatever is being discussed here will be kept confidential. So you should assure confidentiality because when there is a young adult, you don't know, they may not give you
Mm.
history properly. So to for them to be able to tell you, they should have that assurance that it's though she already says I don't want to tell my mother. So though you did
Mm.
persuade her to tell her, that is one good point in that you first try to persuade them, but she doesn't. So you have to assure confidentiality, assess the major concerns. So she's saying because I cannot get sexually active because my leave. So that is what you have to address. Rule out any sexual abuse. Then you should always also ask actually that I'm sorry to ask you at any point of time were you forced to have sex against your will? So that is rules out the sexual abuse. Assess the social circumstances and contraception and STDs. If she's sexually active, you talk about STD screening or contraception as well. Uh, Now, when you talk about the surgery, as far as the applied clinical knowledge is concerned, you say that I understand that you have got your information from the internet, and then you said it may not be accurate. So you can say that as far as the social media is concerned, the images of genitalia shown, they do not show the true picture. Many of these images are retouched, and the real appearance of a vagina uh, is very varied. Okay, and these are generally, they are giving a distorted image. The other thing you have to tell us that you are 16 years old, you are at a young age, and your body is still in transition. So uh, the labia may keep growing, or the anatomy may keep changing until you are 18 and 19. So uh, any surgery, if it is tried at that time, there is a risk that because of the growth of the labia later, the results will become unsatisfactory, and you might require a secondary uh, corrective surgery. Okay, so
Okay.
we say that these procedures are not done very routinely, so we don't have long-term evidence on the probable side effects. They may cause scarring and physical deformity, and later on, it may be difficult for you to have sex if any of these things happen. Then surgery per se, uh, chance of infection, injury, bleeding is all you say. So you cannot be entirely dismissive of these concerns. So at one point of time, you said that the GP also saw that it was a normal, it was normal, and I also said it's normal. Uh, then you are trying to say that the patient is not correct. So I think I would avoid that. Okay.
Okay.
You can
Okay.
say that it seems normal. It's just the normal variation of the vagina. What I can do is I can give you certain. Normally they have thing called as Great Wall of Vagina, in which the various vaginas of the different women are shown, and it shows a lot of variation, so that you can uh, tell her. You did right, because she was not agreeing to you much, so you can say that yes, I can fix a meeting with the consultant. Also, you have to remember that you have to tell her that most of these cases will not be funded by the NHS, so they will be expensive. Around what is mentioned in the Brits PAG guideline is that it's like 1,000 to 3,000 pounds. So
Okay.
NHS
Okay.
will not usually provide this operation. Okay,
Okay.
so
Okay.
and you can say that it is recommended that this kind of operation should not be performed in girls who are less than equal to 18 years. Okay, so this is
Okay.
the information. So you cannot be entirely dismissive of us. And then when she says large labia, you have to ask about whether she has been can any problem in wearing tight fitting clothes, or whether she's inserting tampon or something. This also you should ask. Uh,
Okay. Okay.
then yes, you do offer counseling. You say, but the way you say that, I can see that you are very anxious about it. Uh, would you like to have a counselor who can give you support on this and help you to deal with your feelings in a better manner? She says yes. Okay, but this girl said no. So basically, what you are telling her is, one, that she is normal. Whatever she has seen are the normal variations, and human vagina is quite variable. Second thing is the complications of the surgery, which is immediate and late. Late may be scarring and then dyspareunia later on. And third thing, and the age factor, that because it starts going. And third thing, it is not funded by the NHS. That also she should keep in mind. And
Okay.
I think that's it. So again,
Okay.
history has to be more organized and structured. Uh, uh, it was almost okay, but more structured. But again, applied clinical knowledge, I can agree, because this is a little difficult station to do, because you generally don't read about this. But this station is given the
Yes.
Oxford Task, and is the British Society of Pediatric and Adolescent Gynecology, which is called as the BRITS SPAG. Guideline is there on labiaplasty. So you can read that. Basically, it's like more of a counseling session, and remember the concerns and important things associated with the young adult. So we will be doing young adult when we do sexual and reproductive health. But okay, well done.
Thank you, ma'am.
Okay. So okay, so I've come to the end of this session. Uh, the important tips for the exam: be positive always. This is very important. Please mute your mic. Who's I think Bhagirathi, your mic is on. Okay, thank you. So exam is as simple as it appears difficult. It involves strategic preparation, so you need to understand the exam. Always, always, always listen to the role player. Be calm and confident. Think the person sitting in front of you is a patient in your own clinic. Be empathetic and caring. So last but not the least, Rome was not built in a day. There's still time to go. You need constant and continuous practice, but sure, with each passing day, the more the preparation you do, you feel more and more confident later on. Thank you, all of you, for joining this session, and those of you who want to join the course, the link is in the WhatsApp group. So the other thing I wanted to add was those who will join the course, we are going to make a Telegram group separately. What we did in the last course was that in addition to the usual sessions which are going online, these sessions will be like every week. So before the session, we generally give which module we are going to do. We also give you a list of topics to be done so that you are well prepared when you come for the session. Also, day by day, day to day, we make a schedule to benefit the candidates, in which we take up the Oxford task book, and for each day we will allot a candidate a case, a station from the Oxford task book. The candidate is going to record the station with himself or herself or with a role player with proper timing of 10 minutes, and then as a voice note posted on the Telegram group. Then we all also give or assign a mentor to that candidate. So that mentor is going to listen to that recording on the Telegram group and again record his or her voice note, so that the feedback. So 5 days a week, from Monday to Friday, we do the stations from the Oxford task book on the Telegram group in addition to the usual stations. So I think during the course, at least 50 stations from the task book will be discussed in this way, plus the 80 sessions in the course. So this is something we have added in this course. Thank you all for joining the session. Those who want to join the course can log into the link which has been given in the WhatsApp group, or you can write in to me, personal message me on Facebook Messenger, so that I can carry your request forward. Thank you so much, all of you. Have a good day and all the best for your exam. Thank you.
Thank you.